We'll just have to. Okay, so I want to thank the organizers for giving me the opportunity to present our experience, and I'm going to discuss basic cardiac MRI protocols and relevant pathologies. And first, as I am presenting these protocols, I want to present several of them. We'll see how we're doing with time, but the first issue that I want to actually assess is the assessment of the patient with acute chest pain. So we're going to evaluate the patient who presents acute chest pain. Usually these patients present with elevated cardiac markers such as troponin, and they can present with ECG changes as well. And when we are scanning them, we're actually aiming at several pathologies, and we're trying to differentiate between them. So we're looking at ST elevation of eye and acute coronary syndrome. We're looking at the possibility of myocarditis, and we're looking at another possibility, which is Tako-tsubo cardiomyopathy or broken heart syndrome, and we'll look at that as well. We'll discuss different protocols in order to just evaluate pathologies, not in the acute setup, but just with patients with either known or unknown coronary artery disease in order to evaluate the viability, and then the evaluations of patients with other cardiomyopathies if we do have the time. I'm presenting here the sequences, and I'm relying on the information that the previous speaker has presented. So let's see how we're planning this scan. First of all, what we're using is we're using the standard planes that we've just been shown how to acquire them. So we're using the short axis plane, the 4-chamber view, the 2-chamber view, and the 3-chamber view. And we're using several major sequences. So in the setup of an acute setting, the most important sequence, as has been also stressed by the previous speaker, is the T2 sequence. We're going to use the T2 sequence in order to evaluate for the presence or the absence of edema, and we'll acquire this sequence, I'll show that in a second, in the short axis view. Then following that, we'll acquire sequences in order to evaluate the function of the left and right ventricle. So we're going to acquire sinus sequences, bright blood images, just as we've seen previously, steady state precession images in the 4-chamber view, 2-chamber view, 3-chamber view, just as can be seen here. The FX is the short for function. And then we're going to acquire the real-time perfusion, the first-pass perfusion, throughout the short axis, as was demonstrated, and I'll show you sinus that I hope it's going to run. And then we're acquiring the function of the short axis. We're doing that after the administration of gadolinium because we're trying to shorten our scan time. The whole scan is going to take us between 40 minutes to an hour, and this is a relatively long scan, so we're trying to use the time from the administration of the gadolinium till the time we're acquiring the delayed enhancement images, which is, as we've seen previously, is 10 minutes, and do something within that time, and this is why we're acquiring some of our function images throughout that time. Then we'll acquire our late gadolinium enhancement images as been described previously, again in the relevant planes, which are the short axis plane, the 4-chamber view, the 2-chamber view, and the 3-chamber view. So actually what I'm doing, I'm having the same planes, and I'm looking at the function, I'm looking at perfusion, I'm looking at edema, and I'm looking at the delayed enhancement. Just a short reminder, as we've seen for the delayed enhancement, when we're administering gadolinium, gadolinium is an extracellular substance. So when we're administering gadolinium in the setup of a normal myocardium, by the time we're acquiring the delayed enhancement images, the gadolinium will be washed from the normal myocardium. And therefore, as I'll show in a second, the normal myocardium is dark, is black. There's no gadolinium there. However, in the setup of an acute, either an acute infarction or an acute injury to the myocardium, we have several other physiologic processes that's happening. First of all, we're going to have edema. The extracellular space is larger, so gadolinium is going to be stuck there. And in addition, sometimes we do have injury to the myocytes themselves. And therefore, gadolinium, which was not supposed to enter the myocytes, can now enter the myocytes. And by the time we will acquire the delayed enhancement sequences, gadolinium will be present, we will see. In the setup of a chronic infarction or chronic scar, again, we do not have the normal structure of the myocardium. We do have the fibrosis, and within the fibrosis, we have a larger extracellular space with the myofibrils adjacent to it and the fibrosis adjacent to it. And again, the gadolinium is actually stuck there. So that's just a short reminder. And again, just to demonstrate, we can see here, these are images in the short axis view from the base of the heart to the middle, to the apex. And we can see that this is a normal bone. The normal muscle is totally black, and we can see here again in the two-chamber view, the muscle is totally dark. So in the normal study, the muscle is going to be dark and scarred, or myocardium, which has been either scarred or has an acute injury, will be bright. Okay. The way we interpret our studies, as we're doing with anything in radiology, depends on different patterns. And these are patterns which actually differentiate between ischemic and non-ischemic pathology. And when we are looking at the basic cardiac MRI study, this is the first question that we're asking ourselves. Is this an ischemic pathology or is this a non-ischemic pathology? And again, it has a lot of clinical implications, whether my patient does have an ischemic cardiomyopathy or a non-ischemic cardiomyopathy. As mentioned by the previous speaker, the major point when we're trying to assess for ischemic pathology is the presence of subendocardial involvement. And why are we looking at subendocardial involvement? Just as mentioned previously, the tiny end arterioles of the coronary arteries actually end in the subendocardial layer. And therefore, when we do have an insult, which is a vascular insult, this is the most vulnerable layer, and this is the layer in which we're going to see the first problem. And this is why when we're looking for ischemic pathology, we're looking at delayed enhancement that starts and involves the subendocardial layer. It can be transmural as well, but we're looking to see whether we're starting with the subendocardial layer as well. When we're looking for non-ischemic pathology, you can see that we can have many different other patterns of delayed enhancement. We can have So we can have a mid-wall enhancement here, we can just have patchy enhancement, we can have epicardial enhancement, and we'll discuss that as well. And again, you can see, regarding the different pathologies, we can see that there are different differential diagnoses. So let's start by looking at the case. So this is a protocol that we're applying with the patient who presents with acute chest pain, elevated troponin levels, ECG changes, and let's look at the MR. These are the T2 sequences acquired in the short axis view. So this is the right ventricle, the left ventricle, from the level of the base of the heart, middle V and apex. And as we're looking at these images, the normal myocardium is kind of grayish, and we can see very nicely that there is an area of hyper-enhancement of edema in the lateral wall, lateral basal wall, and it continues also to the level of the mid-LV. So we do have presence of edema. Okay, we're continuing to the first pass perfusion images. These images are a bit jittery, and the reason that they're jittery is we're acquiring that it takes us a bit over a minute to acquire it, as was previously mentioned, and the patient cannot breath hold for the whole scan. Still, we can see very nicely how the contrast enters the right ventricle, then enters the left ventricle, and then enhances the myocardium. Even though it's jumping around, we're trying to look for perfusion defects. And let's look very, very closely. We can see that there is a subendocardial perfusion defect in the lateral wall in an area that matches the area of edema that we previously saw. So we do have a perfusion defect, which also continues here. You see, it keeps on, it's still dark while the rest of the myocardium enhances. Okay. We're continuing to the STEMI images, and these function images we're acquiring. These are bright blood images. They do not require gadolinium. However, as I mentioned before, sometimes we do acquire them following the administration of gadolinium, just because we're trying to shorten our scan time. So as we're looking here, take a very close look at the lateral wall. The lateral wall is hypokinetic. It does not contract as well as the rest of the walls, when we compare it to the anterior wall, the septal wall, or the inferior wall. We can see that the lateral wall here is more hypokinetic, but not only that. If you look very closely, you can see that there is some hyperintense signal within this wall. And as we remember, this was acquired following the administration of gadolinium. So in the STEMI distribution, we do have edema, we do have a perceptible perfusion defect, we do have hyperintense signal on our STEMI sequences in a segment which is hyperkinetic. Now let's take a look at our delayed enhancement images. We're acquiring these images 10 minutes following the administration of gadolinium. We're acquiring that with irrelevant TI, as mentioned before. The normal myocardium is dark, is totally null, but I can see areas of delayed enhancement. So in the same distribution in the lateral wall, we do see transmural enhancement. However, within this transmural enhancement, we do see a very dark area. You can see it very nicely here, and this is an area of microvascular obstruction. So not only do we have gadolinium that enters the injured myocardium here, we also have within it an area that has such a problem with perfusion that gadolinium cannot even enter this area. And the microvascular obstruction has been shown in the literature to be a very poor prognostic sign. These patients will have less of a chance of having a better ejection fraction later. These patients will have much more major adverse coronary events. So this is a poor prognostic sign. As we're looking at delayed enhancement images in other planes, as we mentioned earlier, since this involves the lateral wall, we can see very nicely in the four-chamber view. Again, this is the septum, this is the lateral wall. We can see the transmural enhancement that we previously saw. So this is the patient actually with ST elevation MI. We scanned him 5 days following the PCI, which was done to the circumflex artery, which is seen very nicely in the same territory of this lateral wall. So the hyperkinetic wall, the edema, the presence of delayed enhancement with the microvascular obstruction, which is a poor prognostic sign within it, and on the way we've seen again that the function of the right ventricle is normal and there is no evidence of a thrombus. Let's take a look at the different patients. Again, patient that presents clinically in a very similar presentation, acute chest pain. There is elevated troponin, and there are ECG changes. And we're trying to see whether we're looking at myocarditis here or we're looking at an acute coronary syndrome. And again, these are the T2 images to evaluate edema in the short axis view from the base of the heart, mid and apex. And when we're looking very closely, the first thing is make sure when we're looking at the apex, we do see the hyperintense subendocardial signal. And again, as mentioned by the previous speaker, this of course is just due to slow flow, so we're ignoring that. However, when we're looking here in the infralateral wall, we do see hyperintense signal in this wall. And if we look very closely, we can see that it spares some of the subendocardium. So hyperintense signal, mainly epicardially. Okay, let's continue and take a look at this patient. We're looking at the STEMI images. These images were acquired not following the administration of gadolinium, so we haven't acquired our perfusion scan yet. The bright blood images. And as we're looking at the function of VLV, we're trying to look closely at the infralateral wall here. We do see that it is mildly hypokinetic. So it contracts a bit slower than the rest of the myocardium. As we can see very nicely, the ejection fraction itself of the left ventricle, of course, as demonstrated previously, we can calculate it, and we calculate it for each case. We can see visually that it's normal, as well as the function of the right ventricle. As we're continuing to the perfusion images, we're looking at the gadolinium as it enters the right ventricle, the left ventricle, and the enhancement of the myocardium, and we're not seeing any perfusion defects. So no perfusion defects. There is evidence of edema, and we do see hypokinesis in the lateral wall. Let's take a look at the function images in the four-chamber view, and these were acquired following the administration of gadolinium. And let's look very closely. When we're looking here at the lateral wall, not only can we see that it is hypokinetic, but we can already see that there is hyperenhanced signal here, which spares the subendocardium. So hyperenhanced signal epicardially in the lateral wall. Let's take a look at the delayed enhancement images. There are some artifacts here because the patient was between patient here, and he didn't hold his breath as expected from him, but still we can see that the lead enhancement image is very nice from the level of the base of the heart, mid-LV and apex, and we can see the lead enhancement in the lateral wall, which is epicardial, sparing the subendocardium. And we can see that as we continue throughout the slices. This is a typical image of myocarditis. So delayed enhancement, sparing the subendocardium, as demonstrated earlier when we looked at the patterns. When we're looking at the four-chamber view, we can see the very similar pattern. So this is the left ventricle, the right ventricle, right atrium, left atrium, and we're seeing the delayed enhancement, the epicardial delayed enhancement, sparing the subendocardium, and then we can differentiate very easily between these two entities. So this patient does have myocarditis. Many times we do scan the patients even before they go into catheterization. Once we see such a pathology, there's no need to cath the patient. Okay, let's continue to a different patient. So again, patient presenting with acute chest pain, elevated troponin levels, and again, some ECG changes, and we're looking again at the same differential diagnosis. And here, since I already put the topic there, we are looking for a question of Tako-tsubo cardiomyopathy. So again, we're looking at the T2 images and the short axis view. We're not seeing any evidence of edema, and all these areas with hyperintense signal, these are subendocardial areas, and again, they are due to slow flow adjacent to the tuberculations in the LV. This is not edema, so no edema. We're continuing to the perfusion images, and again, we're looking at the perfusion images, but we're not seeing any perfusion defect. I know it's very quick this film, but there is no evidence of perfusion defect. Let's continue with the function of this patient. So as we're looking at the short axis, this is the level of the aortic valve, the level of the mitral valve, as we saw previously. You can see very nicely the mitral valve as it opens and closes. We can see the tricuspid valve here. And as we're continuing and looking at the left ventricle, we can see that the base contracts very nicely. However, as we continue into the mid-LV and as we continue into the apex, the heart is hyperconnected. It hardly moves. We can see that there is major contraction at the LV base, but we don't see any contraction at the mid-LV and at the apex. And as we continue to look at the long axis views, this is actually the diagnostic image. So we're looking, this is a two-chamber view, the left atrium, the left ventricle. Note how the base, the entrovasal here and the infravasal segment contract very nicely. However, the rest of the heart just balloons out. And the other name for Tako-tsubo cardiomyopathy is apical ballooning. So we do have ballooning of the mid-LV and the apex. You can see that in the four-chamber view as well. Again, base contracts very nicely, but the rest of the heart just balloons out. And this is another differential diagnosis. So apical ballooning, we don't have any evidence of edema. We do have the function images which demonstrate very nicely the pathology. And when we're looking at the delayed enhancement images, we do not see any enhancement. So normal delayed enhancement, also in the four-chamber view and the two-chamber view, and the very typical pathology of the apical ballooning, when we're seeing the base contracts very nicely, and the mid-LV and apex just standing there and not contracting. This is very typical with patients who present with a stressful event or anxiety, and we do see release of cardiac markers since the troponin levels are high, and MRI is very important. Of course, catheterization in this setup is going to be normal. Okay. When we want to assess viability, and this is not in an acute setting, the only thing that we will change is that we're not going to acquire the T2 sequences because we're not looking for edema. We just want to evaluate how much of the muscle is viable and how well does this chamber function. So very similar to what we previously did, we're evaluating for the function in the relevant planes which we just mentioned, the four-chamber view, the two-chamber view, the three-chamber view. We're acquiring a rest perfusion cine images, then we're acquiring the function images in the short axis plane, and then we're just acquiring all the relevant images of the delayed enhancement in the relevant planes. So let's start and look at the patient. Okay. This is 65-year-old patient. He's post-coronary artery bypass grafting. And we can see when we look at the four-chamber view, we can see how nicely the right ventricle contracts. However, when we compare it to the left ventricle, we can see that the lateral wall and the mid to inferior septal wall are hypokinetic. We can see that we can evaluate visually that the ejection fraction of this ventricle is very low. When we're looking at the blood here, note how the blood swirls within the ventricle. Ventricle does not contract as seen previously very nicely. The blood just stands there. By the way, these patients are prone to have LV thrombi, and we are looking for LV thrombi as well, even though it does not have an LV thrombi. When we're looking at the two-chamber view, this is the left atrium, this is the left ventricle. Again, we're seeing that the inferior wall is totally akinetic. It's not moving at all. There is some motion in the anterior wall, although it's hypokinetic as well. And the only thing that really functions is the base here. Let's take a look at the perfusion images. And as we're looking at the perfusion images, look very closely what's happening here. So the inferior septum, the basal level, and the inferior wall, we do see a perfusion defect. And frankly, there's no myocardium there. It's total scar, so we do see that. The other thing that we can also suggest that there is subendocardial perfusion defect anteriorly here at the mid-LV and mildly in the lateral wall as well. Let's continue and take a look at the function of these ventricles. So again, we're looking at the function of these ventricles. It's very low ejection fraction. We can see that this heart does not contract well, as we've seen in the four-chamber view as well. As we're looking at the segments from the level of the base of the heart to the mid and the apex, we can see that the anterior wall and anterior septal and lateral wall at the level of the base of the heart still contract. And as we've seen previously, there is a definite area of thinning and akinesis, even dyskinesis, of the infraseptum and inferior wall, which not only doesn't contract, but whilst the rest of the myocardium contracts, it bulges out. As we continue to look at this LV, we can see that at the mid-LV level, the anterior wall, anterior septum, lateral wall as well, are all hypokinetic. So this heart really functions very badly. As we're looking at the delayed enhancement, we're not very surprised. We see that there's significant disease here. And we can see the scar, which is a transmural scar in the infraseptum and inferior wall, which was totally thinned and dyskinetic. We saw that previously on the function images and the perfusion images. We do see an anterior scar here at the level of the base. However, adjacent to it, there is still viable myocardium. And when we're looking, let's look back at the function images, we can still see that this area does contract. When we're continuing to the mid-LV, again, we're seeing this anteroseptum scar, however, adjacent. Nice. We can still see that there is viable myocardium adjacent to it. And as we continue, we can see that we do see an almost entirely apical scar. However, there is still viable myocardium adjacent to it. As we're looking at the other planes as well, and as we've mentioned previously, each plane demonstrate different walls. We can see that the inferior septal scar here does have viable myocardium adjacent to it. However, in the apex, there's hardly any viable myocardium adjacent to it. The inferior wall in the two-chamber view is totally scarred. There is no viable tissue adjacent to it. However, there is some viable tissue here adjacent to the scar in the anterior wall. How are we doing this time? Mama? Should I continue? Okay, so I'm just going to skip here to the end, and I just want to sum up. So what have we seen? We've seen that cardiac MRI protocols are tailored according to the clinical question. And of course, it's much more complicated than what I have just presented. In the acute setting, the acquisition of T2 sequences is important in order to demonstrate the presence or absence of edema. Function, perfusion, and late Gd enhancement are utilized in most cardiac MRI protocols, and the diagnosis is made, as we've seen previously, by combining the information from all these relevant sequences. Thank you very much, and I want to thank you.